Добрый день, уважаемые коллеги. Разрешите начать сегодняшний вебинар, точнее продолжение цикла вебинаров, которые посвящены проблемам лечения и диагностики колоректального рака. Сегодня вторая лекция, которая посвящена проблемам диагностики и лечения толстого кишечника, рака толстого кишечника. Наш лектор Данко Костадинов, который работает в Королевском колледже Лондона, Великобритания. Позвольте начать его презентацию. Okay. Danko, you can start your presentation.
Good morning, everyone. Thanks again for the opportunity to present a little bit of my thoughts with my presentation then. Thanks once again for the opportunity to present. First of all, today's presentation will be for approaches in diagnostic and treatment of colonic cancer. I want to apologize because I have a technical issue which I will be fixing for next week, as most of my videos from my personal work are not working for some reason, so I need to change that for next time. Just briefly, what is the colon? And as a brief anatomical lecture, colon is usually being consisted of 5 different parts. Today we're going to focus on 4 of them, which is the cecum, the transverse colon, the descending colon, and the sigmoid. We will leave the rectum part for the next lecture. Just briefly, from a colorectal point of view, it's very important to know mainly the anatomy consistent of the blood supply. And the main blood supply coming for the colon is mainly being given by the superior mesorectal artery and inferior mesorectal artery. The rectum is a completely different organ, and that's why I decided to split the 2 lectures, first dedicated to the colon and second dedicated to the rectum, mainly because the rectum is consistent of extra peritoneal part and intraperitoneal part, but also because the blood supply to the rectum is being given from 2 different origins. As you can see, the inferior mesenteric artery is giving a supply to the upper part of the rectum, but then the rectal and the hemorrhoidal arteries are giving the blood supply for the lower part. As well as the rectum is a very interesting organ, mainly from the point that the lymph nodes basin is been completely different from what is been expected in the colon cancer. And as I said last time, every bowel cancer is different. And as you can see here, the distribution of bowel cancers in between males and female patients is completely different, especially when we're talking about localization. And don't forget that colon cancer is very important because it's the 3rd most common cancer, not only in the United States, but also in the United Kingdom. It's all true about the colon cancer. So it's the 2nd leading cancer killer, and it's a silent killer. But most of all, as I said, it's been able to be defeated because I think it's curable. And it's curable mainly because of the different localizations and because we have a different approach to it. As you can see, the most important bit is to realize what is the main function of the left and the right colon. So the right colon is mainly being involved in the absorption of the water and the ions. And unlikely like the left colon, when there is the storage of most of the ingredients, and there is where the stew has been formed. Same thing, there's a huge difference in between when we're talking about colonic cancer, whether the colon cancer is being situated on the left side or on the right side. As you can see that the symptoms can be different, as well as the leading factor from which the colon cancer is being developed on the right side or on the left side is also different. And when I'm saying different is mainly when we're talking about the hereditary cancers, as well as the mutations that have been involved into forming of that cancer. As you can see on this diagram, the cancers that are mainly situated on the right-hand side has a higher chance to have a mismatch repair deficiency rather than the one that are situated on the left-hand side, which has also been very important in management of those cancers, especially when we're talking about prognosis, survival, and disease-free survival. Why is that big of a difference? Mainly because the right-sided cancer is being embryologically been involved into the midgut, rather than the left-sided cancer, and the rectum has been derivated from the hingut. As well as, which is very important for the oncologist, is the mutations. Because the colon cancer and its origin is not purely a surgical problem. It's a very complex problem that needs a very complex approach. And in these cases, I want to keep your attention mainly to see that there is a huge discrepancy in between talking about the right-sided cancer, the left-sided cancer, and the rectal cancer when we're talking about the mutations in the genes. But what is actually the colon cancer? The colon cancer is a stage in which something small in our bowel can make a huge impact in our life. But how is that so much important? Because it's, as I said, it's a silent killer. And there's a lot of factors and causes that are actually involved into it, starting with the genetics, starting especially with family history, starting with obesity. There's a huge discrepancy in between white, like a Black and Asian population. If you're having a background history of type 2 diabetes or inflammatory bowel disease, is also very important. Whereas we're talking about the 6 very important factors, which are mainly change in bowel habit, clear bleeding or blood in the stool, weight loss, pain in the abdomen. But most of those symptoms are non-specific. The advanced stage symptoms are mainly when we're talking about spreading of the cancer into the lymph nodes or into the other organs. What is the effect of the colon cancer in our body? It's mainly, as every cancer, it will lead to iron deficiency anemia, which is one of the pathognomonic factors related with the colon cancer. It can give us change in bowel habit, which mainly as a colorectal surgeon, we're talking about diarrhea or constipation. It can give you bloatness, it can give you constipation, it can give you pain. And one of the most common signs is bleeding from the rectum. Are there any ways to decrease the risk of colon cancer? Yes, there are, and they're usually always related with being a little bit of a healthy life, which means to eat more like healthy, like fibers, decrease the amount of red meat, decrease the amount of alcohol, be more active, decrease your weight, like completely exclude the cigarettes. The main and most important, like leading to colorectal cancer factor, in my opinion, is the colorectal cancer polyps. In general, when we're talking about polyps, as every general practitioner here in UK will say, there are 2 types of polyps, flat and what is called pedunculated or polyp with salt. The reality is that it's much more different than what we think. And as you can see here, this is the Paris classification of endoscopic assessment of colorectal polyps. There are 6 different patterns that we can see, starting from a normal to a completely non-normal, or what is called a precancerous polyps. But usually that cancerogenesis theory takes quite a lot of time, starting from a very small, what is called a hyperplastic or normal polyp, to a precancerous polyp. It takes usually between 10 to 15 years. And as you can see here, we're starting with a hyperproliferation of this polyp, or what it's, as I'm pointing at, the hyperplastic polyp, going through the adenomatous polyp, and then we're starting to have the dysplasia. And if you see a pathological report, you'll see that we're talking about adenomatous polyp or tubulovilous adenomatous polyps with low or high-grade dysplasia. We need to keep our attention mainly on the polyps that start displacing the high-grade dysplasia, which this is the main precancerotic factor. Usually, the most important cancerogenesis factor will be related mainly with the KRAS and the BRAF mutation into 2 different pathways. As you can see on the left-hand side, the MRH mutation and the satellite instability mutations are mainly focused on the right side, rather than the TSC and the MGMT methylation mutations are mainly focused on the left-hand side. As you can see, as I said, there is not only the polyps that might be affecting our bowels and can be a precancerous condition, but also what is called the IBD. And as we can see, there's a lot of different factors associated with the precancerous conditions. The most common types of polyps and their risk assessment are mainly like situated here. And as you can see, the carcinomatous polyps are a very small percentage of them. The bigger percentage are the tubular adenomas and the hyperplastic polyps, which in general has a very low malignancy risk and very low changing in their type potential. As every polyp needs to be screened, there's a lot of different categories, but I think that the Paris category for colonoscopy screening is the most accurate, which usually is saying that when you have a small hyperplastic polyp, even if they're like a significant amount, like 20, the colonoscopy recommendation is once every 10 years. Like in the other hand, when you're having like a very high risk potential adenomas, we need to start making colonoscopy yearly. There are different types of polyps, and as I said, there is like the pedunculated polyp, which, as well as every different thing, needs to have a classification, and the polyp classification has been invented in 1985 by a pathologist, James Hadgett. So this is the classification of Hadgett, mainly for staging of pedunculated polyps. It's very important from colorectal point of view because that classification is giving us a guidelines, especially when we're having a patient with a polyp removed. And as you can see here, there are different levels, and there's a different chance starting from less than 1 up to 25% when the polyp has not been excised fully, or the invasion in that polyp or the polyp stalk has been progressed, in which case we have about 1/4 of the patients that might have a lymph node involvement, even if the polyp has been removed in full. And clearly see here, you can see the different level of approaches, and between 2 and 3 is the one that we will start looking in details into patients and assess whether they might need not only the polyp removal, but also probably a prophylactic colectomy. The other classification that I want to keep your attention on is called the Kikuchi, and the Kikuchi is mainly for serrated polyps, in which serrated polyps, as an endoscopist, I can say it's much more difficult to manipulate and much more difficult to have a better outcome after a polyp removal, mainly because the invasion is much easily spread into the deep surface of the bowel. And as you can see here, the Kikuchi classification is also giving us the idea what percentage of the tumor or the potential polyp has been invaded into the bowel wall, which will also reflect into a discussion later with the patient, whether that patient might need to have a prophylactic colectomy. And as we're talking about the polyp staging, we also need to talk about a little bit about the colonic staging. And in colon cancer staging, we have 2 main classifications. The first one invented in 1950s. It's been done by Professor Herbert Dukes, who is one of the pathologists coming from Johns Hopkins Hospital, who was mainly focused on the colon cancer, and he identified that he needs to have some way of staging a potential cancer. Dukes classification has been used for the last 30 years without any improvement into the staging pattern, which is a good classification, but the problem with the classification is that it just gives you the positioning of the tumor and practically describes the size and whether it's spread or not, but it's not that accurate. That's why for the last 15 to 20 years, the TNM classification have been implemented, and the TNM classification is mainly involved by the tumor, which is staged by a size from TX, which is practically not tumor to be assessed, up to T4B, where the tumor has been not only going from one part of the bowel into the other organ, but it also perforates to the other organ. The M classification is mainly involving the lymph node, starting from no lymph nodes involvement, up to lymph nodes from a different lymph node basin out of the potential organ. For example, in right colonic cancer, we can have a lymph node involvement in the not only in the texture of the superior mesenteric artery, but also in the inferior mesenteric artery. And the distant metastases are usually being staged as M0 or M1. And when you have an M1, it means that a distant organ has been affected by the tumor. Usually, when we're doing the staging, we need to specifically label which organ is that. For example, N1L, which means the liver. In summary, because there are two different classifications, the International Surgical Society decided to make combined TNM and Duke's classification. So in order to see what TNM stage is being mainly affecting the different levels and in which way. So I cannot hear you at the moment. Can you hear me? Let me just stop sharing. Hello?
Yeah, we can hear you well. Everything is okay.
Okay, I can hear you. Should I continue?
Yes.
Okay. So, as I was saying, in order to make an international unified classification, the Dukes and the TNM classifications have been unified, and it's been agreed that we will make a proper staging by using two of them together. And in this way, we need, as a surgical consultants, we need to know both when we're talking about the colorectal cancer. This is how the colorectal cancer looks histologically with different stainings. And if you see a full pathological report, it will be something like this, especially like, for example, this is the one that we're using for our multidisciplinary team meeting. As you can see, that two types of the classifications have been implemented here, as well as from the anatomical side and the prognostic groups. But why is that so much important to know the staging and what, who is practically going to have any benefit? For example, we already talked about how the colonic cancer is very important when you're talking about it, especially when people are having some relatives involved. It is important, especially when we're talking about the familial adenomatous polyposis syndrome. Why? Because that syndrome is having between 70 to 80% cancer risk in every of the family member involved. And this is one of the specimens that you can see how an AFAP syndrome looks like. There are multiple polyps, there are different criteria, but usually it's more than 100 to 150 polyphosis found during the colonoscopy. The percentage of people, as you can see here, it's who might have polyps by age started to grow rapidly in between 15 when we're at the age of 10 to up to 90% when we're about the age of 30. There's a different screening, as you can see, because as an FAP, when a patient has inherited the FAP, it's not only affecting his large bowel, but it's also affecting his other organs like the duodenum, the pancreas, the thyroid, the central nervous system, and the brain. The genetic screening is very important, and that's why once we find out that someone has an FAP, we usually start making the genetic counseling very early in their lifetime, as the treatment is very important. We're doing an annual flexible sigmoidoscopy starting at the age of 10 to 12 until the age of 14. Usually when we start seeing that their multiple polyps start growing more and more, usually we're recommending the patients to have a prophylactic pancreaticolectomy. But as I was saying, the familial adenomatous polyposis is a very small percentage of the colon cancer. Usually the colon cancer is absolutely sporadic. And in order to talking about the genetic predisposition for colon cancer, we need to have a relative who had a colon cancer diagnosed in less than 60 years of age. But you cannot tell if you have polyps because the polyps are usually completely asymptomatic. That's why we need to make the screening. And what is the screening practically? The screening is the best thing that you can have to prevent yourself of getting a colon cancer. And how is the screening being implemented? I can talk a little bit about the screening here in UK, and we have what is called a 2-week wait colorectal pathway from where there is an urgent referral done by the general practitioners to us or to gastroenterologists. And in between the first 2 weeks, we need to make a consultation with the patient and assess whether there is any much of a high risk or not. Usually all the patients are having blood tests, including the two main like test, which will be whether an FIT or a colonoscopy. This is the pathway that we're following here, and as you can see, most of the patients who are more than the age of 60s with change in bowel habit or iron deficiency anemia will definitely go for a testing, including colonoscopy and gastroscopy. We're very adamant of making colonoscopies in patients aged more 75, for which we are recommending CT colonoscopy or CT colonography. And for those that are aged more than 85, we're just making a plain CT with tumor markers and reassessing them in the clinic. Even during the COVID times, our 2-week policy was not changed that much. The only thing that probably changed, in my opinion, was that we've stopped seeing the patients face to face and we're just consulting them over the phone, but the pathway will still continue to work. Are you fit enough? I think the fit is one of the most important tests and most simple way of checking whether someone might have a potential bowel problem or not. Because when the FIT was implemented into our program, we had a huge decrease in cancer incidence, as you can see, from almost with 1/3 of the cases. And we also have a probably like 3 times reduction in cancer deaths related with it. On this diagram here, you can see practically what is an FIT or fecal immunochemical test and the FOB, which is the fecal occult blood test. In UK, we've implemented the FIT test because it has a much higher sensitivity and specificity rather than the FOB. But unfortunately, the price of the FIT is probably 7 times higher. As you can see, it's a very simple way of dealing with it. We're sending the patients the package with instructions how they can take a small piece of their stool and send it to the pathology lab where the specimen will be assessed. And as I shown here, you can see that even that there is a negative screening, the GPs, if they have a very high suspicion that that patient might have a cancer, they can still send a 2-week referral to us for that patient to be reassessed and probably booked for a colonoscopy. And as we're talking about the colonoscopy is the leading role in cancer prevention and early detection. And what is exactly the colonoscopy? It's an invasive test during which we can identify colonic polyps. As you can see, that's usually how we're performing the colonoscopies in left lateral position. We can identify some tissue that we need to take samples or even remove some polyps. But the most importantly, the colonoscopy is a tool that we're fighting cancer. And why is the colon cancer treatment important? It's important because we can consider where the tumor is being situated, what is the size, what is the number of the lesions, if there are any lymph nodes involved or any distant organs. As you can see, the colon cancer algorithm is very complex, and usually it's not just a one-man decision. Usually it's a whole team fighting with cancer. And as you can see here, especially when we're talking about different stages, there's not only a surgical treatment involved, sometimes there is like a specialized or a personalized treatment, like including the biological therapy, the chemotherapy, and then surgery. The new guidelines that we're using started from 2007, where every single colon has been modified individually and every single patient has been seen as a different case, even when we're talking about the same localization and same staging of the cancer. Most of the cases, the histological aspect of the cancer is different. And this is the next upload of the version for the guidelines, which, as you can see, is becoming more and more complex, including the tumor markers, the PET scan, the annual scans, etc. And as I said, usually it's not a one-man decision. It's usually a multidisciplinary team meeting. And in the colorectal cancer pathway, usually it's been involved with radiologists, medical and surgical oncologists, pathologists. Sometimes we have a liver surgeon, depending whether there's any liver metastasis. Sometimes we're having an anesthetic. There is still a discussion whether we need to put the patients into those discussions or not, but at this moment, we are still thinking that it's not appropriate. And as one of my very, very famous professors used to say decisions are much more important than incisions, which I fully agree. As you can see here, there's a lot of different surgical operations that we can perform based on the tumor localizations in the colon. And as you can see here, the gold standard, especially in UK, is the laparoscopic surgery. So every case we're usually starting it as a laparoscopic, and if we cannot perform it, then we can convert. But we're aiming for achieve at least 85 to 90% of laparoscopic, at least laparoscopic assisted cases. On the image A, you can see our setting for a right hemicolectomy, and on an image B, we're usually doing the left hemicolectomy or the sigmoidectomy. This is our usual settings for the right hemicolectomy. So this is the French way of doing the operation with the surgeon on the right-hand side and the assistant in between the legs. This is the way that we're doing the operation. As you can see, we're using the camera and the assistant in a specific pathway, mainly dedicated to have the good triangulations for our right hemicolectomy. This is our laparoscopic pole positions. We're using a 12mm camera through the belly button and 3 5s or 2 5s and 1 12s, depending on the approach. Usually we love to make a diagrams and focusing on the different anatomy. And as I point your attention in the beginning, the anatomy of the right colon mainly involves the ileocolic pedicle. Why I'm talking about the ileocolic pedicle, mainly because this is the most important prognostic factor. And for the last few years, the golden pattern of the ileocolic resections have been invented by this gentleman, which name is Werner Hohenbergen. He's working in Erlangen, and he first described his complete mesocolic excision, which now is being accepted by most of the international surgeons as a gold standard when we're talking about the right colon. So it aims to remove all the lymphatic and vascular tissue in the drainage area of the tumor in a complete and intact mesocolic envelope. Mr. Hohenberger is talking that there is a posterior peritoneum that is covering the large bowel from the surrounding tissue, which needs to attack when you're talking about the CME plane. And as you can see here, depending where the tumor is localized and how many lymph nodes have been involved, this is the area where we're talking about the high ligation of the ileocolic pedicle. If you look at anatomically, and like especially when we're attacking the vessel that high, you need to be aware mainly of the trunk of Henle and the fact that you can damage some of the big vessels situated retroperitoneally. This is a brief diagram just to explain about the right colon cancer and mainly into different areas where you can have the high ligation of the ileocolic artery, including with the D3 lymph node dissection, which mainly has been designed by the Japanese. I personally feel that the D3 lymph node dissection is doable if we're talking about patients who have a very low BMI. And unfortunately, in Western countries, the patients are with high BMI, so the D3 lymph node dissection is not easily doable. But in general, as you can see on the diagrams, depending where the tumor is situated, in order to achieve a complete lymphovascular clearance, you may need to do a proper right hemi, or what it's called an extensive right hemicolectomy. The main disadvantage of dealing with that is first that you need to have a very experienced team in order to do that. And second, as you can see on the diagram B, the extension of the resection is that high that in the end you will end up having an ileo descending anastomosis. There was a randomized control trial which were mainly aiming to see whether the complete mesocolic excision or the CME is much higher in disease progression and survival rather than the D2 proper, D2 right hemicolectomy. And what they find out is that practically it increased the overall survival and increased the disease-free survival, but unfortunately is much more associated with risks and complications. The next stage that I want to keep your attention on is the sigmoid colectomy or the left hemicolectomy. And this is our usual port positioning. We're using a 12 millimeter port to the belly button and 3 5 millimeter ports, or 2 3 5s and 1 12. Usually the diagram on the right side is the one that we're using here in my hospital. And the most important thing there is to make what is called a high ligation on the inferior mesenteric artery. The same way that the complete mesocolic excision was important for the right hemicolectomy, the same way the high ligation on the inferior mesenteric artery is important for the left and the sigmoid colectomies. This is a brief diagram of a perfectly cleared anatomy. As you can see here, the IMA pedicle is being ligated almost at the area of the abdominal aorta. Why is that so much important, and what is the main impact on the patients? It is important because it's been proven statistically that when you're having a high ligation comparing to what you can see here, a low ligation or like an inappropriate ligation, it will decrease your survival rates and disease-free survival. On this diagram here, you can see the different levels in which you can take the inferior mesenteric artery, which from all of them, probably only in picture A, you are practically achieving a better outcome surgically for the patients. As you can see that all the lymph nodes have been removed together with the specimen. And in this diagram, they've also made a comparison between a low inferior mesenteric ligation and the high inferior mesenteric ligation. And it's a completely similar outcome that when you're ligating the artery high, you're achieving a better outcome for the patient, but still the main disadvantage is that you may end up having a worsening in the blood supply when you're planning to make the anastomosis, as well as you need to have an experienced team in order to do that. And I want to put your attention to this paper, which is mainly discussing exactly the one that I've already mentioned, which is the high ligation versus the low ligation. And there is a huge impact in the colonic length and implication of the feasibility for the anastomosis. And last but not least, as I mentioned, there is a learning curve in laparoscopic surgery, and in every experience center, they're going to tell you that the learning curve, you need to be an expert. But in order to be an expert, you need to know how to approach it. Ideally, that's going to be the learning curve that we are aiming for, but the reality is completely different. It's a very steep learning curve, as you can see, with a slow beginning, steep acceleration until you actually reach the proficiency. And once you're reaching the proficiency, there is the point where most of the complications will start happening. Why? Mainly because when you're proficient, the most complicated cases will start coming to you. Because in the beginning, you're probably picking up the easy cases in order to learn how to start managing with them and with the potential complications. This is the actual reality, how a proper laparoscopic learning curve looks like, especially when we're talking about the conversion rate. And as I'm saying, it's not an easy case to deal with complications, but it's unavoidable. And as every surgeon will say, if you're operating, only the one that is not operating is not having a complication. And I can show a brief image of some of my patients. So this is a patient who underwent a right hemicolectomy, and unfortunately he had dehiscence on day 5. This is how his wound looks like a few days before the operation. And this is how the wound looks like a few days after his second operation. Unfortunately for him, he had a leak, most likely a technical issue with the anastomosis, and that's why he underwent a reloop laparotomy, during which we found a small defect in the anastomosis, and we've given an end stomach. Very unlucky, he had a bleeding from one of his inferior epigastric artery, which was stopped with embolization in our intervention radiology department. But a few days later, he developed this skin necrosis. This is the same patient few days before developing the skin necrosis. And unfortunately, I was planning to show you a few of my videos, but I will probably do that next time. So I'm happy for having any questions or any comments.
Thank you so much for your very beautiful presentation. Если у кого-то есть вопросы, вы можете задавать нашему лектору. У кого-нибудь есть вопросы? So there is no questions from the audience. So next week it will be rectal cancer.
So next week mainly will be a brief introduction to rectal cancer, but it will be purely like videos. I will show you the case of this gentleman who leaked. So I'm having a videos. Unfortunately, I couldn't upload them on the PowerPoint for some reason, but I'm going to speak with our IT for a little bit of help. And next time I'm going to show you some of my other cases, some right chemi, left chemi, anterior sections. We have an intraoperative bleeding that we've matched laparoscopically that I'm also thinking that it will be interesting for our students.
В следующий раз предстоит очень интересный вебинар, потому что он будет делиться опытом эндоскопической хирургии, поэтому те, которые интересуются, могут присутствовать. Будет разбор клинических случаев и интраоперационной ситуации при колоректальном раке и раке прямой кишки. Но если нет вопросов, тогда мы завершим сегодняшний вебинар. Thank you so much, dear Danko, and we are looking forward to see you again next week.